My name is Parikshit Sharma. I'm a first-year cardiology fellow in Scranton, Pennsylvania. The title of my poster is "Bleeding is as important as ischemic strokes in patients with atrial fibrillation when it comes to mortality." The hypothesis was generated when we looked at a lot of data from the PCI studies. We know that atrial fibrillation has an increased risk of strokes, and strokes in patients with atrial fibrillation have an increased short and long-term mortality. And we know that oral anticoagulants decrease this risk of stroke, but they also have an associated risk of bleeding events. Looking at the PCI data, we know that major bleeding, which is non-access site bleeding in patients who undergo angioplasties, is associated with increased risk of bleeding. But there is not much data looking at this risk of bleeding in an AFib population when compared to stroke populations. So we hypothesize that patients who have major bleeding events while on Coumadin for atrial fibrillation stroke prophylaxis have a high mortality when compared to patients who have strokes or a control population. This was a retrospective study, so we identified patients from 2 community hospitals out of a database of about 6,500 patients, screening these patients using ICD codes to find out patients with atrial fibrillation who were admitted to the hospital with either a stroke or ischemic cerebrovascular accident or a major bleeding event. Major bleeding was defined using the ISTH definition, which is the International Society for Thrombosis and Hemostasis, which is a 2-gram drop in hemoglobin over a 24-hour period, or requiring at least 2 units of blood transfusion. We followed these patients for the study period, which was from January 2010 until September 2011, and we evaluated these patients to see if they had a mortality outcome. Mortality outcome was collected from patient charts if they died in the hospital or using Social Security database to find out whether or not they died. Interestingly, when we look at our results, we had 65 patients who had major ischemic cerebrovascular events. We had 75 patients with major bleeding events, and we had a control group of 140 patients. The control group was to make sure that there were no confounders. So we matched the control group to major bleeding group patients as well as stroke group patients to make sure that there were age, sex, CHADS-VASc risk factor, as well as has bled risk factor score matched to eliminate any confounders. What we found was very interesting. If we look at overall mortality, that means whenever a patient comes in with a bleeding event or a stroke, as compared to controls, the mortality of both these groups was significantly higher as compared to controls in the long term. But the important thing that we highlighted from the study was that bleeding, the odds of developing mortality in the bleeding subgroup was as high as patients in the stroke subgroup. And the p-values were not statistically different between the bleeding and the stroke subgroups, and both of these groups were statistically much higher compared to a control population. So the first question that came to our mind, are these differences predominantly because of in-hospital deaths or related to the primary event, that is bleeds or strokes? So we eliminated patients who died because of those events and reanalyzed that population for long-term mortality of initial survived events. And that still was very highly statistically significant with a p-value of 0.02 for strokes and 0.03 for bleeds. When we look at subgroups of these patients who bleed, we divided bleeding into intracranial hemorrhages and GI bleeds, because the question would be, is intracranial hemorrhage driving the mortality outcome in the bleeding subgroup? And actually, GI bleeds had a 20% mortality over our follow-up period, and that was statistically significantly different from the control group, suggesting that GI bleeds are also an important contributor when it comes to association of major bleeding with long-term mortality. So I think an important take-home message from this study is that we are quick to make the decision to anticoagulate our patients for stroke prophylaxis, but it is very important to assess the risk of bleeding in this subgroup of patients, because although we can tide them over for the initial event of bleeding, their long-term mortality still remains high. And this is a retrospective study, which is one of its limitations, and that's why it is a very strong hypothesis generating study. So we can do more prospective analysis to see if bleeding really pans out to be as important as stroke in terms of long-term mortality outcomes. And that's the take-home message from this. And I want everyone to take a pause and think about putting their patients on anticoagulants and assess their bleeding risk before they do that. Oral anticoagulants that are now out in the market, the newer anticoagulants, hopefully with their lower bleeding risk, can possibly decrease the incidence of major bleeding and thereby prevent long-term mortality. But our study predominantly looked at Coumadin, and we need more analysis in that, in the newer anticoagulants to look at that exact question.